Hello, everyone. Welcome to Only 2MG Inside the Crisis. I'm your host, Brian Townsend. I'm excited for our next guest, Dr. Michael Miller. I met Dr. Miller on LinkedIn through another podcast and was fascinated by the work he does. And I purposely haven't dove too much into his background, or I know a little bit about his work, but purposely didn't dive too much more into it because I really wanted to draw it out in this conversation. So without further ado, let's welcome Dr. Michael Miller.
Thank you for inviting me back. There is just so much going on in the field of substance abuse. I spend more time pounding away on LinkedIn, commenting, criticizing, suggesting, calling people out on theories that are just based on fantasy. And it's like, why are we not helping? And, especially you in your position, a pre-conversation we had is like, what's the old joke? You got to change it because what you're doing ain't working. And sadly, it's not. It's not. It's the most disappointing thing across the entire spectrum. We're not making any progress. For every jubilant voice that says, hey, I'm no longer a substance abuser, that's great. There's 100 that say I can't get off.
Yeah. You seem like a pretty quiet, reserved guy. You're calling people out. I mean, come on now.
Yeah, I tell people there's many things I've been accused of. Boring has never been one of them.
But I want to learn more about you professionally, obviously, but just give me something to learn more about you as a person. Tell me something, I don't know, unique, different, something, anything.
Well, I'm actually a board certified general surgeon. And so you would say, wait a minute, time out,
Okay.
general surgery. And what it was is, everybody was doing general surgery and I had the opportunity to learn wound care to kind of give you my path. And then I was doing a huge amount of wound care for 30 years, still considered a fairly expert in wound care, and made a lot of house calls. And when you're doing wound care and house calls, you see people in their natural environment and you see a lot of pain. And so my next move was, well, gosh, I need to learn pain management. Well, I'm a general surgeon. We do pain management, but not the kind in the homes, not the chronic, and seeing a lot of abuse leading to the substance abuse criteria, the oxycodones from our good friends at Purdue Pharma. And that harkens back to when I was a young pup in my training, where we were told pain is the fifth vital sign, temperature, pulse, respiration, blood pressure, and pain. And the hospitals were saying patients are not happy because they're in pain. You need to do a better job controlling their pain. And,
Yeah.
we did.
And if you don't do it, you're cruel and you're negligent.
Right. And we're going to cut your bonus because it means your ratings are poor and people are not coming to the hospital. So, and we still have some of those hanger-oners. I'm not going to give you my age of 66, but those that are the generation ahead of mine are now retiring. And what they're leaving behind is, the proverbial little old lady with horrible osteoarthritis on 6 Percocet a day and nothing for the arthritis. And they're telling you it doesn't really help, but by God, you try and get them away from their candy. It's nightmarish. So from wound care, I progressed to pain management, and then seeing what was going on with huge amounts of trepidation said, there aren't a lot of people doing really good substance abuse treatment. And I need to figure this out. And it was terrifying. In those days, they had that 8-hour where you had to take the 8-hour training and get waivered. And then you could only see 30 patients and treat them for the first year. Then it went to 100 for the second year, then 200 for the third year. And then they realized that was crazy. We need more docs treating, and they got rid of the whole darn thing. And now anybody can do Suboxone, buprenorphine based. Methadone requires a little bit more. The issue with methadone is it's not in the same category as buprenorphine. It's, you need a special certificate to have it, but that's it, quite a bit different. And in our practice, we are anti-methadone for a lot of reasons.
Wow. Okay. So from wound care to pain management and then eventually the Miller Care Group.
Yep. Substance abuse. I basically realized that I can't do this by myself. And there were enough people that liked my mission, liked my thought process, liked my business model. And so I will tell you that we have now the entire spectrum of services. We do psychiatric medical management, mental and behavioral health counseling, house call palliative care, primary care in the office, a pain management, low narcotic, but non-invasive. I have some colleagues that do the spinal implant stuff, and of course, wound care. We also are rebranding our lymphedema program because nobody's doing lymphedema. And last but not least, my true calling has finally moved itself into substance abuse. It is something that I enjoy helping people. I have a huge ego, if you haven't guessed, and I tell patients that when you get better, I get a stroke. Now, I don't know what that means. I have no idea how many strokes I have. I don't know what I can trade them in for, but you getting better is my mission. And that's how I get myself up and rousy, is helping someone else do something that they haven't been able to do. Or more importantly, short man syndrome. No one else has been able to help me either.
Well, I love that you're helping people, and that's why I knew I liked you and wanted to get to know you more. You're making a difference in this world, and I appreciate that. So medicated assisted treatment, where it's not just here's some medicine and this will make it better, but you're looking at more of a holistic approach to helping people,
Yeah. When I
mental
started
health.
this,
Yeah.
Yeah, when I started this, it was I can't do this as a pill mill. Several of the large, major entities that I won't name, like Groups and Clean Slate, they don't have the A part. And I keep saying the concept is not M, it's MAT, and I've changed the A to medication assisting
Wow.
the treatment,
Okay.
not medication assisted treatment, medication assisting the treatment. And the treatment is because it's pain, especially in the opioid arena. And I know we're going to talk about meth, but opioid is all based on pain. It's based on physical pain, the oxycodone, but it's based on psychological pain. Anxiety hurts, depression hurts,
Yeah.
PTSD hurts, schizophrenia hurts. That's real pain. And if you don't make the diagnosis and you don't treat that, they self treat.
Yeah, they self-treat, right. It's getting to the root of the problem, right? We know people, some people are just using drugs because they just, they wanna see what it's like, right? But we know a lot of people are it's something much greater than that. They're escaping maybe, like you said, a different type of pain or trauma.
Mhm. I don't hear much about the euphoria seeking. In the old days, a million years ago, where, well, I like to get high, okay, fine. You don't hear that now. Mostly now, especially my long term, they're afraid of withdrawal. I am afraid of withdrawal. I tried to get clean, and after 4 days, I absolutely could not do that. We talk about a medication called lofexidine, Lucemira, which has been out 9 years, and it is the only FDA-approved medicine to mitigate opioid withdrawal. And yet, it's one of my favorite questions: is like, have you ever heard of it? It's been out, 9 years. And people go, no, never heard of it. I say, well, wait a minute. If you're talking about high blood pressure, you need to know 150 medicines. When you're talking about opioids, you only need to know one, other than Vivitrol. And Vivitrol is a lovely entity as itself. But how do you get to the Vivitrol? Well, you got to get through withdrawal. And how do you get over withdrawal? In our world, it's Lucemira. And it really mitigates. It's not perfect, but overall, it's been great. And yet, oh my gosh, nobody's heard of it. The sales force for the company was not big. I don't want to be critical because God love them for getting it out there, but it just wasn't pushed the way it should have been. But you can make an argument for the example for Vivitrol. Even now, Vivitrol is just starting to peak and it's been out years.
9
It's
years. Huh?
horrible.
Yeah,
Horrible. Yeah. It's like,
but
here's a medicine. Yeah, I call it the bulletproof shield.
interesting. You talk about that dope sickness and
Yes.
yeah, I agree, and I hear that quite a bit from folks I talk to is, in fact, there's a video I play, and when I talk about, when I talk about fentanyl,
Mhm.
a young lady says, "I don't care how dangerous it is. I don't care how many times I overdose. I don't care how many times I die. The withdrawal symptoms are so bad, I'm willing to take that risk." And I think that's something that a lot of people just don't understand, where it's no longer, like you said, there's no euphoric feeling they're chasing. That was the first or second time. It's just, we have to avoid this pain at any means necessary. And wow,
Absolutely.
you're seeing
And,
that every day.
Yeah, and it's a badge of honor. Like, I'm now abstinent, I'm now sober, I'm no longer using. It's great. How'd you get there? Oh my God, it was 2 weeks of absolute nightmare.
Wow.
And then you have pause, post addiction withdrawal syndrome, where they're cruising along good, and then all of a sudden they get cracked again.
Yeah.
And oh my God, what do I do? Well, what's the easiest thing to do? You call up your friendly neighborhood narco man,
Yeah.
and oh, it's and again now it's not even pure. You know, the articles we're reading, the even the marijuana now is not your mother's marijuana. It's significantly, it's just,
Much different, right? Yeah.
yeah,
And
it's better
and
living through modern chemistry.
and they're already self medicating themselves. So now let's say you've been clean for a month and before that your tolerance was really high and
Yeah,
you don't know where your tolerance is yet. So you might use more of the drug thinking that your tolerance is still higher than, let's say, the first or second time you used it. And
yeah.
that puts you in even greater danger of overdosing because now you're taking more of the drug that you may not need.
Yeah, that you've lost whatever tolerance you had. It's horrific, and we see it across the spectrum. Having mentioned pain management,
Yeah.
we have the proverbial little old lady coming in, and we're getting ready to put her on a series of medications for chronic pain. And of course, we are 100% you pee in that cup drug screeners. We 100%. And of course, there's an 80-year-old lady with cocaine in her system because her grandson came over and saw grandma was in pain and said, "Here, grandma, take this pill. It's something I got. It'll help your pain." And these little old ladies are just, what?
Wow.
I don't do that. Well, maybe not, but here's a piece of paper and here's a cup that shows. So it's so ubiquitous. And that's the problem is you don't know what you're getting. You have
Yeah.
no idea what you're buying. And that's the most terrifying part.
I agree. I mean, I look at the National Forensic Laboratory Information System, the NFLIS, which is basically a database that DEA runs, and they look at all the illicit drug supply, the evidence submissions by law enforcement, and now we see. I mean, the last time I looked, it's like 40% of cocaine now is co-reported with fentanyl.
Mhm.
18% of the methamphetamine out there. I mean, of course, heroin. Good luck finding heroin, right? I
Yeah,
mean,
I jokingly say to someone, they say, "Oh, I've been doing heroin." No, you haven't. Heroin hasn't been in the United States for 4 or 5 years.
it's
If you got heroin, I know a lot of people that would like to talk to you, but, no, it's not here anymore. Fentanyl's a dead drug.
yeah,
Yeah, now it's all fentanyl and the stuff they're mixing in,
oh,
all the tranquilizers, the
xylazine, yep.
animal tranquilizers, most of which I have the darndest time trying to pronounce, Mr. G. It's just amazing. And the
That's
and
how
the
I feel with the other
pathologists,
drugs.
yeah, and the coroners are saying, "Well, first case of xylazine and first case of this and this one." It's like, "Oh my god," you know?
Magazines, it's incredible, and there's unfortunately, there's people who are just in their basements mixing these drugs together, what we used to call them designer drugs, now we
Yeah,
call them psychoactive novel substances, it just
true.
or NPS, yeah, it's incredible, but let's talk about meth. I'm really
Yes,
fascinated
yes.
by the work you're doing with this.
Yeah, so, I jokingly call myself I'm the little kid that's gotta ask why. And so when I started learning about opioids, the why was easy. You use opioids to treat pain, as I previously discussed.
Mhm.
You have pain, opioids are for pain. That's a 1 plus 1 equals 2. No problem understanding that. But meth, I kept saying, why in the heck would anybody want to rev themselves up into a state of chaos? And then you start to do your historical research and
Ugh,
you learn that the Reichstag during World War II at the Nazi meetings was using a similar methamphetamine to keep awake. Japanese kamikaze pilots did methamphetamine prior to taking off to allow them to, without conscious, crash into planes. I don't know if it's still true, but I researched in the Philippines and several other countries, they give the workers methamphetamine to increase worker output.
wow.
And interestingly, methamphetamine is a DEA class 2. It's not a class 1 because it has medical indications for ADHD and weight loss, which blew me away. I said, that's outrageous. So, the benefits. But what I kept saying is, okay, so why are regular people using this? And, the things that we are aware of is we know that the homosexual, the gay population use stimulants, cocaine and methamphetamine to promote sexual activity, erectile enhanced performance, and other things. And that's a tough thing to treat. If you've got someone using it for that, that in our protocol for treatment is like, look, yes, it's okay to make love, but can you do it without endangering your life? Because your urine just showed me not just the meth, not just the cocaine, not just the crack, but there's xylazine in this, there's fentanyl in this, and but the meth crusade came basically because I started to just do something very unusual in medicine. I listened, and coming from someone as talkative as I am, I know that seems divergent, but I would say, what does methamphetamine do for you? And over many, many patients in about 9 years now, I kept hearing two distinct stories and with no overlap. And story number one was, boy, I'll tell you what, I use it because I have no energy. Well, we're all chronically tired. I know that. And we'd all like more energy. But these people, as they used to say on the TV show, hee haw, they're get up and go, got up and went. They had no, and I don't think in terms of energy, I think in terms of arousal, brain arousal. They just couldn't get anything done. They would say, I get the kids off to school and then I can't move. And I differed it from depression because I had my psychiatric team as part of the A. And they would say to me, no, I'm not picking up a lot of depression here, my mental health team. Not a lot of depression. I'm like, well, why would they do this? And, without beating the dopamine and all that other stuff, basically it was, what can we do to increase their arousal? So that I called category one, and I called it LISA, low internal state of arousal. And it simple, easy acronym to remember. And
Right.
and the stories that I kept hearing were the same, and the workup that we do, not to kill my workup, was, I asked them, what do you do? Well, everybody has had some sort of occupation at some. I'm a waitress, I'm a warehouse worker, I did whatever. And the workup is basically, how many people that did what you do? How many warehouse workers? How many waitresses? How many whatever? And then the real clicker question is, of all those people that who's the best? Who's the best at their job?
Hmm.
My category ones are never the best. Well, Joe's better. And then I would jokingly say, well, I just killed Joe. He's no longer alive. Who's left? Well, Bob. And no matter how many scenarios I present to them, they're never the best. Whether they're using meth at that time or not, they have no arousal. I would come in late and I would leave early and trying to get them to commit. If I called your boss, would he tell me that you were the best worker he ever had? No,
Yeah.
absolutely not.
Just
He
going
was,
through the motions then.
they just could not put two and two together. And it's like, well, that's crazy. Okay. So the question then was, all right, so they have no arousal. What do you do? Because I am anti, and this is opinion only. I don't believe that adults can have ADHD. ADD we can talk about all day, but the H stands for hyperactive. And hyperactive kids, we all know somebody that has one. They run, they jump, they scream, they kick out chairs, they're defiant. And when I ask an adult, do you act like that? They go, no, they put me in jail. So how can anyone assume that you have the H? So stimulants in my world are, for all intents and purposes, forbidden in adults. So what do? I've got patients with no arousal that need stimulation, but I'm not giving them stimulants. Well, there are a lot of great meds that are non-stimulant stimulants, like Provigil for shift worker syndrome, where your day and nights are off and you can't get your arousal together. Provigil, New Vigil, there's another one called Wakix that we haven't had the chance to use. This increases internal arousal. And then, because I don't believe in the magic pill, we use medicines that in normal people would make them all hyper, like Wellbutrin and mirtazapine, Remeron. So our cocktail for those that we make this diagnosis is we put them on Provigil, and we put them on either mirtazapine or we put them on Wellbutrin. And you've got the statistics to see what category one. It is the smaller percentage of those that are methamphetamine. And we talk about meth, but I bundle it all together into stimulant addiction. So
Gotcha.
crack cocaine, meth, all of that. Even though the research was based solely on meth, I don't have a problem extending it. And once you put these people on it, it takes 72 hours to see the change. It's outrageous. I've been doing it 9 years, and I will tell you that I'm still blown away by how quickly it happens. The worst part of all is it's very matter of factly. I say, well, how are you doing now? Good. I mean, what does good mean? Well, I'm not craving meth anymore. Wait, say that again. I'm not craving meth anymore. Wait a minute. Aren't you a meth addict? You destroyed. Yeah, I know, but I'm not craving it anymore. It's almost counterintuitive. Like, no applause, no explosions, no fireworks. Nope, I'm not craving meth anymore. And again, the numbers at 72 hours blow you away, and full effect at 2 weeks. The percentage plummets of methamphetamine craving, because in the research we did, we looked at two components: craving and what's in the urine. And what's in the urine was really important because, I mean, objective and subjective.
Yeah.
So if they were craving and the urine was dirty, that was a negative. It wasn't working. But we also want to know why, Well, I wasn't craving, but I had some friends come over, the infamous friends, and they didn't bring a cheese basket and crackers. They bought meth. And I'm a nice guy. I didn't want them to use alone. So I did a little bit, and then I feel terrible. So, but that's the category one. Again, I call them Lisa.
So
The
that's part
but
of your diagnosis then? So
yeah, yeah. That's one of the reasons why is they have no arousal. And
wow.
the problem is the workup, I'm almost ashamed of it, is simple. You know, they're get up and go, got up and went. No matter what they do, they just can't get it together. And they've tried coffee and they've tried the super drinks and everything. And meth is the only thing that they perceive gives them the energy to do what they need. In fact, it really doesn't, but their perception is they get more done. I have stories of a guy who had 5 children from 5 different baby mamas, and he worked in the warehouse and he was doing meth and he had triple the output of everybody else. And he was using meth. Why? Because he had 5 children to take care of. So, how's that for an ethical dichotomy as a doctor? On one hand, I'm saying, buddy, you're a stand up guy. You have 5 children that you are doing everything you can to give them the life they deserve. But as Dr. Michael Miller, maybe we can find another way to do it without you doing methamphetamine first thing in the morning to get you know. And the other gentleman was somebody who liked nice clothes, nice cars. He worked in a warehouse. He would do meth in the morning, do double, triple the output of everyone else. And then his buddies would give a oxycodone at night to slow him down. So those are outliers. Those don't fit the protocol, unfortunately, as do those using it for sex. But you would be amazed in just chatting with people that are methamphetamine users or not, that this subset of this population of what I call Lisa, they're out there. Everybody knows them. They're the nicest people that no major personality aberrancies, and they never get anything done. You would never trust them to pick up your kids because there's always an excuse. I'm sorry, I'm late. Something happened. And it's repetitive. It's not single, on and on and on. So giving them these non-stimulating stimulants or non-stimulant stimulants night and day. And again, the statistics show, 86% response rate at 2 weeks.
Wow. Is
Urine
there a lot
control, yeah.
of the A and MAT with that
Oh
cat?
my God, yeah. Yeah. I wanna make that clear.
Yeah.
Anybody that is in our program must have mental and behavioral health counseling and must see a psychiatric medical provider. That is
Yeah.
mandatory. After you have seen them, if you and they decide that, you really don't have that bad of depression, okay, but
Yeah.
I defer. I'm not a psychiatrist. My psych team has the proviso to, if you think they've got depression and you talk to the patient, we absolutely have to have the A. That is ubiquitous throughout the entire program. No excuses, no exceptions.
Yeah, no, I gotcha. Okay. So I'm curious, well, what overall percentage? I mean, is this
10 to 15% are category one.
okay, 10,
Now it's funny
15%.
because initially when I first was learning the protocol and realizing that everybody's exhausted, in the first year or two, everybody was going on Provigil and Remeron because they were all complaining about tired. And then they weren't getting better, or they were getting a little better. And I'm like, I'm missing something. What am I missing? Because one size doesn't fits all. And to kind of digress, when you look at the ASAM publication, the 200-page publication on methamphetamine and stimulant addiction,
Mhm.
they had 0 studies that they said had any content. In fact, the only thing they said that had any bearing was contingency management, which is bribery in my mind, and that had a 17% success rate. And basically what you do is you say, here's the deal, Brian, if you don't use meth, I will let you put your hand in the prize bag, and it may be a sticker, it may be a bubble gum, it may be a thing for McDonald's, and it's response reinforcement reward 17%. And that's what they're touting
Wow.
as the treatment for methamphetamine. Now, the funniest part of the side story is a very good friend of mine who's in that organization. I did a podcast with him and I taught him the protocol and we did a patient live. And I called him on the phone and said, hey, just catching up. How are things going? He said, I don't think it's working as well for me as you. I need to get better on the protocol. And I said, well, how are you doing? He said, well, anecdotally, he says, I don't know. I think about 50%. And I broke up laughing and I said, you toad. I said, the best statistically nationwide is 17%.
Yeah.
You telling me you don't know what you're doing, and yet you're 50%. You're triple the national average. I said, my God, my heart's breaking for you. You're helping 3 times as many people not being sure of the protocol. And that's both kidding, then whatever. And he just laughed. He
Wow.
just laughed. God love him. So to me, that was the proof that this is not a lightning strike. It's not just me. This makes sense. And then the second, more prevalent, is my category 2.
Okay.
And not being a psychiatrist, the issue was just trying to figure out, and I jokingly tell people I'm a smart boy, but I'm not that intelligent. I have to have things simple. So I kept hearing the same thing over again. And these people were aggressive, like road ragey kind of aggressive, and they were airheads. They'd forget what they're talking about. And they would lock in on something, where you have to dynamite them to get their attention, the old squirrel thing. And the more I looked at it and kept hearing it, all of a sudden the light bulb went off and I said, well, this is ADD, for God's sake. These people have ADD. And the 3 components that I see routinely: one, hyperemotionality. Okay. And I say to them, look, how do you have a significant relationship? Not just sex significant, but significant. And I say, yes, I do. I say, all right, what would happen if your significant other tells you you're dressing funny or whatever? If you get in a fight with them, are you going to stand your ground, defend yourself? Or are you going to retreat? Or are you going to come at them and they go, well, yeah, I have a bit of a temper. I can get pretty nasty. 99% of the road rage we read about in the newspapers, they have ADD. I don't need to diagnose them. It's this uncontrolled hyperemotionality, and it's either expressive, and everybody knows somebody like this, where you say something not quite right, and they are in your face, ready to rip your head off.
Yeah.
And then 5 minutes later, they're your best friend. They can't figure out why you're mad at them. Oh, I didn't mean it. When I called you all these profanities, I was just kidding. You shouldn't take it personally. And it destroys relationships because the partner is not going to put up with this that long. No way. And then retentive, where I say, given the choice, if someone came to you and was very aggressive, would you stand your ground? And no, retentive, they'll say, no, 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 I'm backing off. I would rather back way, way off. I don't want to get involved, whatever. So it's some sort of uncontrolled hyperemotionality, and that's number 1. The second one I do, because you always want to be complimentary. You're asking a lot of personal questions of these people. And the second part I ask him is, how much education do you have? Oh, I have, and it doesn't matter what they have. Oh, I have high school, or I didn't finish high school, or I did whatever. And I say, well, you're obviously not a dumb person. I mean, you may have 3 years of high school. You're obviously intelligent. Say, so how often, and watch what my hand's doing. How often when you and I are having a conversation, do you suddenly airhead, space cadet, astronaut, ditch? And they go, all the time, all
Huh.
the time. They continuity of thought is gone. And I say, what happens with that? They say, it drives me crazy. People are always saying to me, why aren't you paying attention? Or all of a sudden, I may have started the conversation and I can't remember what we're, oh, it's beyond frustrating. Yeah, they're gone. They're gone and they can't get it back. And that makes them more angry because they had something important to tell you and they can't remember it. So the 2 major components are the hyperemotionality and the loss of continuity of thought. The third I have is hyperfocus, and that's where they're locked in. And I say, so you're locked in, you're reading a book, and your significant other says, hey, Brian, for God's sake. And it does it. Oh God, that happens all the time. I have to forever. It's hard for me to pay attention. And once I'm paying attention, you have to use dynamite to get that. And those 3 components, the hyper concentration being the least prevalent, though not much, it's a no brainer. In fact, I had patients that came in. The story my team loves to tell is the lady that came in and I said, it's very nice to meet you. We're hopefully going to help you. She said, great. I've had this problem for a long time and I really, wait a minute, what was I going to say? And my team went,
No, they knew right away. Number two,
two,
this is
two. I
not
said, I
a
looked at him, I said, do you want to finish the workup or should we just treat her? And then, no, 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 finish the workup. And what do we treat? So I tell people legitimately, you can't treat methamphetamine. There's no treatment for methamphetamine. There's nothing. However, I treat ADD.
Oh,
And,
interesting. Okay.
and so I treat ADD, and in treating ADD, I'm treating methamphetamine because again, the FDA says there's no treatment. ASAM, 200 pages, nothing works. And yet again, the statistics speak for themselves, and we crunch them and crunch them. And, I talk to my team, make sure you're sending the statistics to the PhDs to put in the spreadsheet. And, this recent go round, and I'm a wonderful speaker educator. I'm not a great writer. So I had some help from some PhD MD colleagues who published massive amounts, and they taught me and trained me and commented and criticized and critiqued. And again, as of last Sunday, the paper was submitted to the Journal of Addiction Medicine. So far, no rejections, but I've been trying to teach this for years. I've begged ASAM, poster, put me on the podium, let them shoot arrows at me, let them challenge me to what I'm doing. Because when I talk to people like you that aren't medical, they say, well, that makes perfect sense.
Yeah.
This makes perfect sense. Of course, there's nothing. I talk to lay people. That makes sense. But when you talk to men, it's like, and yet nobody's published anything worthwhile. So for me, it's been a labor of love that has been beyond frustrating because I mean, it's almost too easy. I hate to put it in those terms. This has almost been too easy. It happens right in front of your eyes with little provocation.
Well, and I want to talk about your numbers, but before we get there, and I know we mentioned them, but okay, so I'm struggling with methamphetamine addiction. I come to you, I sit down for this consultation, this diagnosis, and you're going to put me in one of two cups. I'm either a Lisa or I'm struggling with the ADD.
Yeah,
Is that
and by the way, the second one I call chronic, aggressive, agitated, absent, attendant presentation, CAP. And that was the original thought. And then I said, "You idiot,
ah,
that's ADD."
wow?
So I still call it CAP for my terms. It's ADD, pure and simple.
So the treatment plan is going to be based on this initial assessment,
That's
this
it.
diagnosis.
You're an airhead and you have hyperemotionality, you got ADD, and my psych team and behavioral team make sure there isn't anything that's possibly causing that.
Yeah,
Because
yeah.
comorbidity is easy, but not that is the soul. And there's nothing. There's nothing.
Wow. Okay. So you've sent me the results, and I'm
Yeah.
very impressed with them. So let's talk about it. So your results are a lot higher, and like you said, you would love for these other organizations to come and say, "Hey, what are we doing? Did you do this? Did you not do this?" I mean, try to plug holes in it. I mean, because you're
Oh
seeing
God,
it
yeah. I
years
beg
and years
people.
and years.
I beg them, please tell me I'm out of my mind. Show me why this doesn't, listen, I'm not afraid of rejection. And the problem is there's been rejection after rejection. They didn't like this. They didn't like, that's why this final incarnation, I'm so delighted because it ran through this PhD MD couple who are just tyrants. They're the loveliest people you'd ever want to meet, but they had no bones beating me up, and my PhD colleagues from Marian University who crunched the numbers, who have published extensively. It went through these guys with a fine tooth comb and a shredder. And at the end, they said, we're done. This is it. If it doesn't get published now, we have no explanation why not. So and again, I'm on LinkedIn, I'm on Facebook, I'm also on TikTok where we talk about this. And I get calls from all over the United States. I mean, even a program like yours, Brian, where someone says, "Hey, I saw you on Brian Townsend's podcast. Can I ask you some questions about this?" And it's like, by God, yes. Ask me all the questions you want.
Yeah.
Punch holes in this. Punch holes in it as hard as you can. Please find reasons why it shouldn't be working because it works.
Yeah, I'm not a doctor and don't have that scientific background, but when I look at your numbers and we've talked before, and I look at this, I mean, are people scared because it seems so simple? Surely there must be a problem with it. I mean, what's going on here? Like, because I
Uh,
mean, why
I hate
wouldn't we look at this?
paranoid. I hate to be paranoid. It ranges from everything. Well, I think the cartels are buying the societies so that meth doesn't die, which is silly. To let me get this straight. A board certified general surgeon in Indianapolis, Indiana, of his own volition has come up with this and it works. Not buying it. Not buying it. And, some very eloquent colleagues of mine, that are very prolific and well known have said, can't tell you why, Michael. You satisfied me, but ASAM every year has rejected both the poster presentation and the podium presentation.
No reason, just
No reason. So,
reject.
but it may be that it isn't published, even though how many papers are being published that are crap. And so right now, pending the acceptance for publication, my only hope is that we will see increased, because I'm out there saying, listen, guys, I've got 89% success. It was 86, by the way. Now it's 89.
Yeah.
And it's, does that matter? No, as long as I'm better than 17.
Yeah, I mean, I I think those results speak for themselves, and if
Yeah.
I were someone that was struggling from substance use disorder and primary, stimulants like meth, I why wouldn't I wanna take that, chance, that opportunity to to be treated by someone who's had that type of success? I mean, it's a no-brainer. I mean,
Right.
I would invite, it sounds like the medical community is trying to, poke holes, but
Not
and like you
yet.
said, we welcome that opportunity. At least that means they're looking at it and they're, and that challenging it's good because it'll show that it does work, or
Yeah.
maybe there's some areas that they can discuss. But wow, interesting. So how many what's your footprint like in Indiana?
Well, right now in Indiana, numbers go up and down. It's funny when all is said and done, everybody in Indiana's substance abuse treatment numbers are down. All the detox rehabs are down. The sober living transitional. I don't know why, but everybody's down because we don't have an inpatient presence, and arguably, meth doesn't need to be inpatient. And no one's doing anything for it. Detox, no problem. Withdrawal management, no problem. That's all in pay. Meth, I'm doing this, in my garage. We can do this without them being in there. And again, because I have the benefit of in-house psychiatry and in-house mental and behavioral health therapy. So we are a rare entity in that we are a one-stop shop for all this. And again, I'm thrilled to teach. I've had people reach out, NPs, addictionologists saying, I saw this, talk to me about it.
Yeah,
And, like I said, with my friend who's only 50% poor guy, you know. So
that
we got to get the word
89%.
out.
Yeah,
But
we got to get the word out. You're absolutely correct. So if I'm listening to this and I want to get in touch with you, how do I do that? I know you said
oh my
LinkedIn.
gosh.
TikTok,
Yeah,
What's the best way?
LinkedIn, Michael Miller on LinkedIn. TikTok, that's my favorite, but I don't dance. There will be no dancing by Michael on TikTok. I tell people that, doc at Miller Care Group, millercaregroup.com, DOC at millercaregroup.com. Shoot me an email. We are thrilled because the last question I ask anybody that I present, and yourself excluded at this point, is, does this make sense? Does this make sense? Because if it doesn't make sense, then I'm not doing my job. And that's a statistic we don't keep, but it's 100%.
Yeah,
Anyone we do that says, and the failures that we have are failures because of external forces, the infamous friend. Or if they come in and they're dirty, then I say, are you on the medications? And just to name the medications, we were using a medication by Lilly called atomoxetine, Strattera. Very good medicine for ADD. This is category 2, by the way. Very good medicine, except it takes a long time to get on that. And so we more recently have been using a medicine called Qelbree, Qelbree. It is, I'm told, the fastest growing medicine to treat ADD. And it comes in a couple different strengths, and we start them off mid-strength. And the neat part is I tell the patient, you control your dosing. Don't ask me. I'm going to start you off on 200 for the first week and then 400 milligrams the second week. At that point, you're going to tell me one of three things. It's working, leave me here. It's too strong, can I go back down? Or it's working, can I go up? And I'm going to say, yeah. And last, I don't believe in the magic pill theory. So as you saw with category 1, I use 2 medications,
mhm,
and the medication we use with category 2 is called Intuniv, guanfacine 10x, same name. It is a medicine indicated itself for ADD. I use it in a symbiotic fashion. And on those rare occasions, thank God, where someone is using, their urine shows up, the first question is, did you pick up both medicines? Are you taking both medicines? 90+% of the time, well, I wanted to try just one, or I didn't pick it up. And when we say, look, there's a reason for this, take them both. Once they're on both, it's 89%.
That's incredible.
Right. Yeah.
Let me recap. Somebody comes in, it's a brain arousal, Lisa, or
Yeah.
it's ADD, and that's what we treat. And we are seeing success from both. 89% is overall
Yeah.
treatment success. Yeah, this is a no brainer. I don't know
Yeah.
why we wouldn't invite other folks to dive deep into this. And
Crucify. And again, like my team was looking at the numbers and said, boy, they're great because what we do is we have a 2-week run-in period. You need to be on the meds 2 weeks before it counts, because if not, then we haven't done anything. Once they're in the 2-week run-in period and we see them, then we backtrack and say, okay, the urine at 2 weeks is clear. Great. You've been on the
great.
meds. Great. So the 2 weeks counts, because you got to be on both meds. Then
Yeah,
it's at 1 month, 2 months, and 3 months. And when we look at the 3 months, the statistics of success still hold good, but the overall numbers drop. And that's consistent with every other study that we see. At month 2, you lose them. At month 3, you lose them. Lots of reasons why, but are those that stay on the numbers hold true. The statistics hold true. If you stay on it, we can help you. And we're getting more and more long-term, 1 year, 2 year, 3 years, even though we don't crunch the numbers out that much, that are saying, no, I haven't craved for months, years. Yeah.
so we're looking at cravings, and we're looking at their urine.
Urine.
Yeah.
Yep. That's it.
Wow, this is interesting. I would encourage anyone listening to learn more about Dr. Miller and his work, and
We're delighted to share because we got to get the word out. I keep
yeah,
telling my wife, I'm a smart boy, but I can't be the only one in the world doing this. And no, yeah, I'm the only one in the world.
wow,
No one. And you look, and it's problem because they're just throwing stuff. Well, let's try Vivitrol and the GLPs. Oh my God, we helped somebody. Well, everything worked for somebody once, but there's no consistency. And that's why it's like, why are you not making a diagnosis? Why has no one else sat down and shut up and let these people tell them their story? Because that's how I did it. I
yeah,
jokingly tell people the reason for my success, we do something very, very unusual. We make a diagnosis.
yeah, we listen.
We listen.
Well,
Sad, hard to believe.
and from my perspective, from the illicit drug world, I mean, meth is not going away.
Oh
That
no.
we don't realize. I mean, obviously, I have an interest in educating people about fentanyl and other public safety threats, but meth is still the most seized drug in most of the U.S. and
I would agree.
overall, 100% the most seized drug by law enforcement. And in law enforcement, we always say meth is king because I mean, we see more meth than anything else. And now I know fentanyl is taking over in some states, but yeah, crazy. Wow. Well, thank you so much. Any last words? Any?
I and my team are here to help. I can't tell you what a thrill it was to connect with you again.
Yeah,
Um,
absolutely.
any chance I have to get the word out, I do with that. Conferences. I'm forever on LinkedIn saying, hey, the California subsidies. Anybody speaking about methamphetamine? No. Well, I'll pay my own way out there. Let's do something. The American Osteopathic AOMED is coming up in October. And, I have this, like, I wonder if the paper will be accepted and published by then. I wonder if someone will invite me up on a podium to talk about what we're doing and have somebody punch holes in it. It's a great fantasy. It may not be till next year.
Wow.
ASAM, I have some good friends that are on ASAM. And even the last submission, they said, I don't understand why I wasn't selected because one, nobody's talking about it. And two, you've got good numbers. So
Yeah,
that shouldn't matter. Bad numbers should be good also. A failure is as good as a success in what we're doing. Knowing what doesn't work is just as important as knowing what does work.
absolutely. So if you're watching this and you want to learn more, or you want to, well, you know how to get a hold of Dr. Miller. But if you know any of these folks, share this.
Yeah.
Tag them. Let them challenge this, because this is good information. This is this is good results. They
And we
really
do
are.
live consultations. I tell docs, listen, if you get a methamphetamine user, let's do a Zoom. Introduce me, and then I will show you the workup live or whatever. I said, a while ago, I still had that trepidation, like, oh my God, it's not. Oh no, not anymore. I'll take on all comers. If you're a primary methamphetamine user, though, it's not someone that used meth because they didn't want to withdraw from fentanyl. If you're a primary stimulant abuser, cocaine, crack, or methamphetamine, we got you covered.
It's almost frustrating because it's such a no brainer. I mean, if I were struggling or if I have a family member struggling, why wouldn't I want to try?
Yeah.
I mean, maybe I'm that 11% that's not successful, but you know what? My odds are pretty good that what you're doing is pretty good based on the research we've seen and the results we've seen. Why wouldn't I? I mean, I just,
Boggles
people,
the imagination. Boggles the
family,
ima I have no good answer, nor have I gotten a good answer, you know?
and as you know, and people struggling with substance use disorder, addiction, and the families and the people they're close with. I mean, this really impacts so many. Why wouldn't we want to put people on a course that could potentially help them? I just
It
it's frustrating.
it is. It's very frustrating, and yet there's a sense of jubilation when someone comes in on methamphetamine. It's almost like, "Well, we got a new patient for you. What's their drug of choice? Meth. Oh, good. I wanna have a good day." I'm gonna have a good day. Not that we don't have, we're huge users of the long-acting injectables, the Brixadi and the
Oh,
Sublocade for opioids. We think they are the bee's knees. And then, of course, everybody in our world must wind up on Vivitrol, must, because I like it as a bulletproof shield. They say, what does it do? Nothing. Doesn't do anything. It just sits there minding its own business unless you try to drink alcohol, in which case it blocks, unless you try to use opioids, in which case it blocks. We've been doing this long enough, but you got to make it easy for people too.
yeah,
And I say that I'm going to try and make this as easy as I can. All you have to do is take 2 capsules and 1 pill in the morning. That's all I'm asking.
yeah.
And if you do that, you got an 89% chance of never craving meth again. Is that something you can do? And most of the time they can.
I, I know it's well. You mentioned some other drugs. Let me just ask you about Suboxone real quick when it
Yeah.
comes to opioids, and because we're seeing a lot of Suboxone on the streets now.
Yeah.
In fact, even in the jails, other than the synthetic marijuanas and the cell phones, we're seeing a
Yeah.
lot of Suboxone strips. I'm just curious your thoughts on Suboxone.
The issue I have is the better Suboxone than fentanyl mentality, and or better methadone. And I mean, LinkedIn, or whatever, Facebook. I've been on methadone 10 years, and I'm at 165 milligrams, and they don't want to wean me because they're afraid I'll withdraw. The issue I have is that as a scientist, as a doctor, this crap is bad for your body. I did a TikTok talking about all the horrible things that the opioids do long term. Now, chronic pain, I'm not going to take those people on, because if you're in chronic pain and opioids are all that work, you're a different entity. You're a different entity. But
And
the
it's small,
Suboxone
right?
stuff, what's that?
And a small, I mean, we're talking about a pretty small segment, right? I mean, of the
That's
crime.
very, very small. And I do pain management. We use Suboxone. We use buprenorphine in pain management. If you're in chronic pain and you have no quality of life, function and quality of life is really what we key everything on in
Yeah.
our entire practice. Suboxone I like, but the problem is you get into a pattern like cigarette smokers, the 2 fingers, the touching it, inside, and so the Sublocades, the Brixadis, by going injectable and long acting, we wean. They
Yeah.
self-wean. They depot like female hormones, and they slowly just go down, down, down. Of course, we give them a prescription for Lucimira in the unlikely event, like 0, that they have any withdrawal, in which case I say, you know what? Give it to somebody as a Christmas present. Give them the Lucimira as a Christmas present, because you're not going to need it. But again, it's that mentality of, well, I don't want a shot. Well, yeah, but it's an easier way to get off. And with the Sublocade and Brixadi, we're weaning patients off in 6 months. 6 months with MAT, but 6 months. Yep.
Yeah, that's incredible.
Yep.
Whew. Well, I've learned more than I thought I'd learn. Well, I mean, not that I didn't think I'd learn from you, but I was looking at your numbers and just so impressed. And the last time we talked about the previous time you looked at the results, and I was like
Yeah.
blown away by it, and happy that we get to share this, and hopefully people will be interested in this, and also share this with others, and encourage them to see how they can help people as well. So,
Brian, you're a
Dr.
rock
Moore,
star.
it's been a pleasure.
You are
What's
a
that?
rock star. You are a rock star getting the word out. The stuff that I see on your podcast is extraordinary. I am honored and privileged to have the chance to get out there and tout my stuff. And again, if we can help one person, then
Hmm.
I've had a good day.
Absolutely. And we're going to look for more ways that we can collaborate. I
You
think there's,
bet. I'm
yeah,
in. My wife
absolutely.
wants me out of the house. Keeps throwing that R word at me. That R word. It's like not yet, not yet. Soon.
Yeah, yeah, yeah. I retired in 2022, and much busier now, but I
Yeah,
enjoy it. So,
true.
yeah. All right. Well, thank you again. I appreciate you, and we're going to put your contact information on the screen, and
Got it.
hopefully you get just inundated with messages and phone calls. So,
Got it. I'll let you sign off till I figure out how to work this laptop.
thank you for listening to Only 2MG Inside the Crisis. I hope you enjoyed this episode, and Dr. Miller as much as I have. Be safe, take care of each other, and be the change you want to see in this world.